Okay, let's start again. It's Lauren Van, and I have the privilege of being on the Commission on Aging for the City of Pleasant Hill. I'm also the City of Pleasant Hill's appointee to the Advisory Council on Aging. I welcome you. This is a workshop that is put on by Pleasant Hill Commission on Aging and also Pleasant Hill City Council. Five couple of our commissioners that are in the room. Miriam, did you want to stand up? She is a commissioner on aging, and also back at the registration table, we have Dana Simmons, who is also a commissioner on aging here for Pleasant Hill. The commission puts on workshops throughout the year, and we're very excited to present this workshop to you on palliative and hospice care. We ask that you do evaluate the workshop. We have a QR code at the end, and please give us any input, any additional information that you would like to see on future workshops. And then just to give you a little bit, we are on Zoom. So we have people registered who are watching the session on Zoom today. And then anybody who needs to use the restrooms is located out the door and to the left. So with that, I would like to today on palliative hospice care. We know there are many hospices here. And we have asked for okay, are we good there? Okay. We have asked Hospice East Bay to give this presentation to palliative and hospice care. They are our neighbors across the street, our Western, and they also are huge support for the community of Pleasant Hill. With us today, we have Deanna Bennett and Dr. Chang, who will be giving the presentation. What we'd like to do is we'll have question and answer, but if you could hold the question and answers till the end so that we can present all the information and possibly answer your question along the way. Let's see, with that, I do want to point out that there is one slide that our hospice presenters might not go over too much in depth. And it's a set of questions that you might want to ask a hospice agency when you're looking to select a hospice for you. So when that slide comes up, if you want to just take a picture of it on the monitor, that'd be great, but all the information is here. So with that, over.
Well, good afternoon. As Lorna mentioned, my name is Deanna Bennett. I'm the Director of Community Engagement for Hospice East Bay. I'm going to have Dr. Chang, who's our Medical Director. She's going to present on both hospice and palliative care, and then I will come back to join her at the end of the presentation for any Q&A. So welcome, everyone.
Hi, thank you. Is this what I use advance? Okay, and just for the people who just arrived now, this presentation is being recorded, and we also have people on Zoom. So we would like your consent in our recording and to be able to ask questions. Just so I get an idea of our learners today, do we have anyone in the healthcare field or social services? Anyone? Okay, great. All right. And so I'm going to be talking about hospice and palliative care. So before I go into there, here's kind of a first myth. Hospice means a person is going to die. That's the first myth we hear, first myth that we hear. And in fact, the earlier that you receive hospice care, there are more opportunity for your loved ones to really benefit from the full services and scope of hospice care provided by a team of different professionals who can address all the different symptoms and stress that may be causing the loved one and the family and caregivers around them. And there's more of an opportunity to stabilize the medical condition. Second myth, families have to pay for hospice care. So hospice care or hospice program, it is covered by your insurance. Whether you have Medicare, Medicare Advantage, or commercial insurance, it is all covered, and the benefit you receive, you are entitled to receive if you are eligible and should you decide to elect hospice program and services for your loved one or for yourself in the future. So we're hearing the word palliative care and hospice. And what is this, what are the similarities, but most importantly, what are the differences? So you see a diagram, a circle with a smaller circle inside. And palliative care is specifically for patients who also are on curative treatment, but they also want to focus on quality of life. There is no specific prognosis. So this could be someone who has a diagnosis of cancer, but they are also wishing for chemotherapy or treatment, but they want to also continue to maximize their quality of life and live successfully in the community as long as possible. So palliative care, that is kind of the umbrella. And hospice is inside the umbrella of palliative care, specifically for patients where doctors would feel would have an life expectancy of 6 months or less, provided by an insurance. So that is the difference between palliative and hospice care. And the focus of hospice is primarily on comfort. Before we go further, I wanted to acknowledge Cicely Song. It's Dame Cicely. Is the mother of the modern hospice movement back in the 1970s in London, St. Christopher's Hospice. This is kind of going in and out. This one, okay. Is this on? Okay, okay. And the modern hospice movement it came around in the 1970s when Dame Cicely Saunders founded St. Christopher's Hospice in London. And what she was a nurse and a social worker. And what she recognized was the concept of total pain, that when people suffer, it's not just physical suffering, but there is emotional suffering, feeling loss of autonomy when a disease progresses or a medical condition progresses. There's also social pain people experience when they are suffering from a serious condition, where they are worried about being a burden onto others, or losing autonomy, or worried about finances to care for their medical care. And there's also spiritual suffering. People's relationship with God or relationship to yourself also comes into question when you're diagnosed with a serious illness. So she recognized that all of these areas, whether it's spiritual pain, social, physical, and emotional pain, need to be addressed at the same time, because it's not just the body, but it's also the mind and spirit and the relationship unto others that will guide one's perception and quality of life. So it's through her that the modern hospice movement was established and came to the United States following Florence Wald, a Yale nurse administrator who brought the concept of hospice to the United States in the 1970s after visiting Dame Cicely Saunders. So what is hospice? So primary emphasis is quality of life provided in your home. It's not a place you go to because it's a program. It's a hospice program covered by your insurance benefit, and it is provided where you live. It is specifically for people who are considered to have a prognosis of 6 months or less, with the goal of the care primarily around quality of life and comfort. And the other philosophy is that you're accepting of the natural disease progression. So it's less about trying to cure or control a disease. It's more about allowing the disease to take its natural course, provided by the team, the hospice team, in your place of residence. Who is eligible for hospice? We discussed for patients whom 2 doctors feel could have a prognosis of 6 months or less. Some examples of hospice eligibility would be someone with an end-stage neurological disorder, for example, who's had a stroke with a significant change in your function, where you're primarily considered bedbound, or dementia, ALS, where you're now having difficulty leaving the house or primarily approaching bedbound. End-stage pulmonary disease, emphysema, COPD. Now, these are all spectrums. You can have COPD, but still be pretty functional and driving, and that's probably you won't be eligible for hospice. But it really is a spectrum through which you have to discuss with your physician to determine if you could be eligible. But we're really thinking closer towards the end stage, where it's now they're becoming more bedbound with hospitalizations, needing more support in the home, thinking about infections or in and out of the hospital. This is when we are starting to think about hospice care program for evaluation. And then advanced cancer, when someone has either metastatic cancer or the cancer has come back and it has spread to multiple sites, and you're no longer wanting treatment, like chemotherapy or immunotherapy. It's more about focusing on the symptoms related to the cancer rather than controlling the cancer. What encompasses hospice services? It's provided by a team, like we addressed the total pain, the emotional, social, spiritual, physical pain. So it requires a whole team to provide the support to the individual. So that we have nursing support, emotional and social support for the patient and family, volunteers, medical equipment, supplies, bereavement support, or grief support, we say, care provided in your place of residence. Again, it's not a place you go to. The hospice team comes to you where you live. Medications related to quality of life or comfort, and also 24/7 access to nursing support nights or weekends should anything come up. This is the basic hospice service included in your hospice benefit as part of your insurance plan. And this is all required by the government to be considered a hospice agency. This is the minimum requirement to be licensed and accredited. Again, you have, and more specifically in terms of the personnel, you have physicians, nurse practitioners, nurse case managers, medical social workers, spiritual care counselors, home health aides, volunteers, and grief counselors that all provide the hospice support to address the total pain. And also support for the loved ones, the caregivers who are caring for them, because it is hard for them too. And so they need they also need the support. There are 4 levels of hospice care that is included as part of the hospice program. the top, which is called routine level of care, majority of our patients are at home or in their place of residence. Around 99% of our hospice patients receive this nationally. Continuous care is also care provided in the home if, for example, the pain or symptom becomes unmanaged and you need a bedside nursing support for 8 hours in a 24-hour clock. Respite care is another level of hospice care, really to provide respite for the caregivers. For example, if the spouse is the primary caregiver and they need at least a break, the respite care's hospice program recognizes that caregivers need a break, whether it is to travel or to attend to other activities. And it's 5 days max each time it is taken. An inpatient facility is a place patients could go to if the symptoms or they have unmanaged symptoms that cannot be managed in their place of residence. But it's just an acute stay, a short period of time, a few days or so before, it can become stabilized or the symptom is managed, and then they would go back to their home or residence. But it is a place where there is 24-hour nursing care to try to get that symptom managed before they go back home. And all of the, hospice programs should be able to provide any of these levels of care. It's not expected for you to know this. It is expected for the hospice agency and the providers to know what level of care is appropriate for the loved one at any given day. But just for you to be aware of, all the different services and levels of care that the loved one can receive. There will be some variation among different hospice programs who want to differentiate themselves among other hospice programs. So there will be varying degrees of special programs and services. So these music therapy, pet peace of mind, veteran-centered care, inpatient hospice facility, and grief services for children and teens, they will have varying kind of specialties among hospice programs. These are not required to be a hospice agency. These are kind of a way to differentiate themselves. I'm going to go and talk about palliative care program. So palliative care, it is a medical specialty for people who have been told they have a serious illness. Some of the examples could be emphysema, COPD, heart failure, cancer, dementia. The goal of the palliative care program is to improve quality of life for both the person and the family, provided by a team of doctors, nurses, and other specialists. So they work together and closely with their primary care doctor and, for example, the heart doctor or the cancer doctor. And palliative care's the goal is to be an extra layer of support, appropriate at any age, at any stage, and can be provided with curative treatment. The goal of palliative care is to empower patients and families, to allow them to live in the community setting on how to care for themselves and advocate for themselves, addressing goals for care on how to live well, what's meaningful for them, care coordination, and working closely with your other doctors like palliative care, the primary care doctor, the cardiologist, or a cancer doctor, and organizing care conferences. Palliative care is really great at looking at the big picture. Sometimes it can be very confusing to have 4 or 5 different doctors and you're wondering, is everyone talking to each other? The goal of palliative care is to really, help to coordinate and make sure everyone is on the same page, be an advocate for the patient and for the families, and so that the patients feel empowered to advocate for themselves and to live as well as possible in the community setting based on what their goals are, what it means for them to live well. In palliative care services, the payment for palliative care, it is, they bill Medicare or private insurance. It would be similar to any type of outpatient visit that you would have with your specialty doctors. That is about it for our talk. I talked about a lot, so what questions do you have? Like over there. Mhm. Yeah, so, yeah, you're correct in that. I think it's specifically when we talk about patients who have been diagnosed with cancer, and even if their oncologist is wanting to cure the cancer, you might get side effects from the treatment or from the cancer itself. And so I think palliative care wants to show is that specifically for cancer, that you can still get palliative care support even if you are living with the cancer that can be cured. So it's specifically for cancer. That's correct. Yes, over here. The very last. Yeah, it would be whatever your insurance. I think anytime you see a physician, your insurance will cover a certain amount. And some insurances, there is a copay for you. And so it would be similar to your visits seeing a primary care doctor or a cardiologist or a lung doctor. It would be billed the same way. And some of those do end up having copays. It really depends on what is set up with your specific insurance. What we wanted to just be clear is that it's not 100% covered all the time, depending on which insurance plan you elected. With your insurance company. Yes. Medicare covers, for generally speaking, my understanding is Medicare covers 80% of all outpatient visits. And then usually patients would pay the 20% for palliative care. Yes. Hospice is different. Hospice is covered 100% by your insurance. Yes.
I can't hear. I wanted to share just a couple of experiences. Backing up what you've been saying, I took care of my mom, and I was very knowledgeable about what her benefits were. I knew, and I cared for her until she passed away in our home, 95. I'm involved with caring for someone that I only knew socially. She called me when she was in the emergency room. And it took me 3.5 weeks to figure out what she was about.
Mm.
She had been because she had dementia. And she 46 years retired from Kaiser, but it took me a long time. So I encourage people to have their affairs in order in all cases.
Yes, I also support that. Whether you are just like we prepare financially for our future, and some people create a power of attorney for their financial trust. We also recommend creating, I think with the lawyers, they call it a durable power of attorney for healthcare. But it, you know, in the hospitals, they'll call it a healthcare directive, and you would designate a power of attorney for healthcare. That is a very important, is something that I would recommend to everyone 18 and older. And we're doing that for ourselves because you just never know what can happen. And so I do recommend creating a power of attorney for healthcare. And also in those documents, it states, you know, what is important for you to live well and what you would want. Sometimes they give scenarios on, you know, if something happened, what you would want. And it gives an idea for your care persons or your power of attorney. It gives them an idea on how they can support you should you be unable to temporarily or permanently advocate for yourself.
She did not have power of attorney, and she invited me to be her power of attorney. If I had not been a decent, caring person, I could have taken advantage of her in a second.
Yeah.
I don't care if you're 77. I am all set up. Everything's in. It's so critical.
Any more questions?
Yes.
This isn't so much of a question, but something that's my observation is there's a lot of confusion about home care services provided by Medicare. And um, having been a home care provider, you know, I know how the patients come up, and I know a lot of people have that. And the difference between palliative care services and hospice has a lot to do with the types of in-home care that people can expect. But that doesn't mean there are no home care services for palliative care. Is that correct? I mean, like, you could have home care services for directed professional needs under palliative care.
And there are different models of palliative care. So palliative care can be provided in an office, an ambulatory setting. It can be provided by video visits and phone appointments, and it could also be provided in the home. So there's a different mix of ways palliative care is delivered, and it's a medical specialty. So sometimes our palliative care patients will benefit from home health, which is a skilled nursing service. So generally speaking, palliative care may not provide this skilled nursing support like wound care or Foley catheter or drainage care that home health provides. Home health is different. The philosophical approach for home health is it's rehabilitation following a hospitalization or a major surgery, and you need a skilled nurse coming to the home to help with some dressing changes or drains or Foley catheters, provided with sometimes physical therapy or occupational therapy following a stroke, for example. And that is only a certain number of visits that Medicare will approve, let's say 3 to 6 visits before, you know, it is considered the person is rehabilitated and then discharged from home health program. If you do not improve, or if you stabilize, or if you are, or if you improve, you get discharged from home health. It's a skilled benefit purely around the philosophical approach of rehabilitation. And that could, some home health agencies have palliative care kind of mixed with it. So it just depends. And some hospices have home health and palliative care kind of mixed as a business model. So it really depends on kind of where you are, what stage is your illness, what you are looking for in terms of your goals and what you hope to achieve. And hopefully working with your provider, you can find the right program that will fit for you at any given time. But we also know that disease evolves And you may not need home health, but you may elect hospice because hospice does not always discharge unless they are considered improving. Even with, decline, hospice will continue to care for you even beyond the 6 months. And we have many patients who stay with us beyond 6 months because we don't have a crystal ball. We can never say for sure, someone's length of life. But sometimes with the care of hospice program and their loved ones and empowering their loved ones to care for the patient, they do live longer than 6 months. Do you mean one hospice provider program? Easy? I mean, it's if you're a Medicare beneficiary, it's your Medicare right to elect who your provider is going to be. I always recommend, if you're not happy with the service, to have a care conference with the team and discuss what are the expectation and goals for the program. And it may either be one, you're just not happy with their services or their communication, or two, you might be looking for a certain program that the one hospice agency does not provide, but another does. Or three, you may realize your goals may no longer be aligned with hospice care and you may want to go back to the hospital, or you are improving. Let's say you had a stroke and you started hospice, but you never know, and you could be improving and gaining in function, and you realize, look, I want home health and I want physical therapy now and I want to improve. So it may also be that your goals are no longer aligned with hospice. So I think the first step is meeting with your care team and discussing what are the expectation and what are your goals. And is hospice continuing to be the right goal for you? Because that is always fluid and dynamic.
But there's this miracle drug that the FDA has.
Yeah, if someone were to call.
I'm going to ask Deanna Bennett to answer.
Yeah, that's a great question. So if you call our agency, we'll need an order. So we'll just kind of ask some questions on who your PCP is in the community. We could reach out to them to get an order to admit the patient on hospice. But one of the things we really like to do is to go out and do an evaluation. So we have staff, we have nurses, healthcare nurse liaisons that will come either to your home, or if the patient is at the hospital, they will go to bedside and have the conversation on what's going on with the patient, what's been going on the last 6 months. We'll get all of that information and then we'll set up admission if the patient is appropriate, and we can do same day admission. So we can do it as quickly as same day if needed.
Decades ago, I was a bereavement counselor for husband. Is it a volunteer counselor?
You want to answer that? So we have bereavement counselors in our bereavement department, so they are not volunteers.
And she does have hospice, but I didn't understand that they need physical therapy and pain medication.
Answer that, so
Yeah.
that's
You-
my wheelhouse.
Okay, we'll let Lorna answer that.
There's the residents, the home residents. There's assisted living. There's board and care, and there's skilled nursing facility. There's homeless shelters. All of those can be accessed by hospice. We could service for hospice there. A board and care is kind of like a step down from assisted living, where they're licensed by the county. They're in your neighborhood, you just may not know it, they're homes. They have a limit of 6 people per home. They have to have 2 caregivers during the waking hours and 1 caregiver at night. So if you look at the ratio at a boarding care, it's terrific compared to assisted living. And I'm saying that as a big bias, but I ask anybody, it's not the end of the road. It's a type of care that a family would choose. If you were at an assisted living, you would pay for your board and care, and then you would get this whole step down of additional charges, medication management, housekeeping, caregiving, assistance with dressing and all that. At a board and care, the person is assessed and a monthly charge is given, and that is an ongoing monthly charge. So a board and care is not a step down, it's just another alternative way of caring for an aging person.
Add to that, you could be on hospice and not be on.
Absolutely.
Correct.
Absolutely.
So if you're on hospice, then you're. That's why we don't have the.
Where she is, they don't do any therapy under hospice.
Correct, that's correct.
It's home health. Home health is the program where they provide it's along the philosophy of rehabilitation. So they provide. Hospice may provide a one-time physical therapy. As the disease progresses, you may need more. You may have a change in your assistive device from wheelchair or walker to wheelchair, and you need education on how to stand, transfer, pivot, and correctly use the wheelchair without falling. So they provide a one-time education for proper training, use of assistive device, as well as training the caregiver.
I mean, they even came out and helped me transform the house so it'd be easier. I think
We like to call hospice a gift.
Mhm.
Are there any other questions?
The idea of whatever treasure I have managed to accumulate to be spent at somebody's shovel into I decline is really the thing. I would hope that, is there, you get to the point where you can't do stuff, you can't do what you want. And the things that give you joy, you're not able to do. Is there a way just getting shot for fee? Is there a way of, my plan is I would stop eating. Fear that somebody if we just want to get the
So, I mean, everyone's going to have their own viewpoint on what is quality of life for them.
There is California does have the age of dying law. It's been here since 2016, and it was just revised a couple of years ago. And as it stands now, you have to be cognitive aware. You have to have 2 doctors within a 48-hour period give a that you are cognitively aware and that this is your choice. One has to be verbal, one can be in writing. And then you have to be able to actually administer the drug. The doctor will prescribe the drug. The problem with that is it's all volunteer. So there is a website, I'd be happy to provide that. But, you know, the doctor has to in and have to volunteer and has to be somebody that is willing to give that referral. That it is legal in California. And I will say that statistics that many people do go through the process, get the prescription, but never take it. I think it's that mental security of knowing that you have it. But that is by law in California legal.
And you would have to, the two doctors would have to say you were not coerced into making the decision and have a prognosis of 6 months or less. Yeah, I would recommend talking to your primary care doctor so they can assess and continually, talking to them and having visits to have them determine if you are eligible. Well, they won't be able to say whether you're eligible. It has to be the two doctors who are participating in the program. But we often recommend going into hospice if you are considered to have 6 months or less, just so that you and the family, if there's family, would have the support. Not all hospice agencies do, support the program, or they have varying degrees. They have their own policies and procedures. Ultimately, the patient has to take the medication themselves. And the Medical Aid in Dying or the End of Life Options Act in California is not paid for by Medicare, and they are very clear about that. Yeah. Yes.
I'm going to give you a website to go for information. Any other questions? Well, I really applaud you guys for being here to learn about hospice. I thank you guys, Dr. Chang and Deanna, for joining us and presenting this presentation. Before I say goodbye, are there any last minute questions? Okay, a couple of things. I just want to say we have a vacancy, the Commission on Aging here in Pleasant Hill. So if anyone is interested, you might want to visit the Pleasant Hill website, and that would be pleasanthillca.gov/vacancy. We also have an upcoming workshop on Medicare. As you know or may not know, October is open enrollment. So anyone on Medicare right now who would like to make some changes or just want to get some updates on Medicare, that will be Wednesday, September 18th, between 10 and 11:30 here in the City Hall. And we encourage you to register for that. And then finally, if you could do us the favor of filling out one of the surveys and just let us know how we did today, what we can do differently. If there's a topic that you would like us to explore for a future workshop, we would appreciate that. So thank you and have a good afternoon. Excuse me, one moment, Juanita. Okay, the Zoom people, we want you to survey us too. Thank you.